nakita nyo ba yung yung wala. Wala. Fail. Wait. Wait lang. Teka, di ako makapapayat. Wait lang.
Doc, nakamute ka po.
Sorry, may kausap ako. Anyway, nakamute talaga ako.
Sorry.
Ayan. Teka. Ay, nakita nyo na yung sagot. Ano ba yan? Sige, pabilisan na lang. Nakashare na ba ako ulit? Hindi pa. Wala pa. Pero you can see sa phone ninyo. Alam mo, hindi talaga siya nag-aaral. Anyway, sige, may part 2 tayo later. Pag after ng lecture na lang. So, mas madaming makakasagot. Okay, sige. So, later na lang yung quiz natin. Para mas maraming maka-join. Practice lang yun. Practice. Okay. Yan. Kita niyo yung slides?
Yes po, Doc.
Okay. Okay, so today we'll be discussing the basics of pediatric ECG, and our objectives are the following. So to present the common indications for requesting a pediatric ECG, define basic terms, present similarities and differences between pediatric and adult ECGs, and to present basic pediatric ECG interpretation. So this is just a definition of what is an ECG. It's a graphic record of the changes in the magnitude and direction of the electric current generated by the depolarization and repolarization of the atria and the ventricles. So when do you need to request for an ECG? So these are the indications. First, if you want to determine the cardiac rate, if you want to document the rate, of course you can do it via auscultation, but if you want to document it, you can request for an ECG to get the actual rhythm, to check for signs of chamber enlargement or hypertrophy. If you're considering myocardial infarction or any intracardiac conduction disturbances, and also to aid you in the diagnosis of acquired heart diseases. In pediatrics, so these are the common indications wherein we get referrals for ECG. So if a patient presents with syncope or seizures, which may be syncopal attacks may be a seizure equivalent, to rule out neurologic or cardiac cause. And then if there are exertional symptoms, if there's drug ingestion, presence of tachy or bradyarrhythmia, if we're considering congenital or acquired heart diseases. So first, let's go into the limb leads. So maybe this was discussed already in your ECG lectures before. So as a review, we have 6 leads. So first, 6 limb leads. So you have the standard bipolar leads. For lead 1, it's from the right arm to the left arm. So the direction is towards the positive side. So from the right arm to the left arm, that would be the axis of lead 1. For lead 2, from the right arm to the left leg. And for lead 3, that would be from left arm to the left leg. And for the augmented unipolar leads, you have AVR, which stands for the right arm, AVL for the left arm, and AVF for the left foot. Okay? So imagine that you have the patient lying down. So the right hand of the patient corresponds to the AVR, AVL is the left arm, and then you have the middle of the foot as for the AVF. Okay, so if you're, for some institutions, it's the interns who do the ECGs. So for you to know the proper placement for the limb leads, this is our mnemonic. So you have to place the white lead at the right arm, the black lead at the left arm, the green lead at the right leg, and the red lead at the left leg. So for you to remember that, just think of the snow on the grass. Kasi snow yung white, tas green grass. Snow on the grass, and then smoke over fire. So sa BLS or sa PALS, yan ito yung turo nila. Smoke over fire, so black over the red lead on the left. Okay, for the pediatric chest leads, so we're familiar with the 12 lead ECG, no? But in pediatrics, we usually request for the 15 lead ECG. So you can also get the right-sided leads. So for V1 to V6, you have the following. So V1 is on the 4th ICS, the right sternal border. V2 is on the fourth ICS, left sternal border. V3 would be halfway between V2 and V4. V4 on the fifth ICS, left midclavicular line. V5 on the left axillary, anterior axillary line. And V6 on the fifth ICS, left mid axillary line. And then you have V3R, which is halfway between the V1 and V4R. V4R is the mirror image of V4. And then you have V5, which is in the left posterior axillary line. Okay, so first, let's familiarize ourselves with the ECG paper. Okay, so if you see the graph paper of the ECG, there are big boxes and small boxes. So yung solid lines, yung thick lines would correspond to the big box and the thinner lines would correspond to the small boxes. So each line, horizontally, the big box would correspond to a 0.2 seconds and the small box would correspond to 0.04 seconds. While for the gain or the voltage, one small box corresponds to 0.1 millivolts. And these are the wave segments and intervals that you usually see in the standard ECG. So you have PQRST, U. Bakit yun? Hindi ko rin alam. Maybe if may ma-discover na ibang waves para meron pang leeway, but I'm not sure. Basta PQRST-U, yes siya. Okay, so what do they represent? For the P wave, it represents atrial depolarization or the contraction of the atrium. And then you have the PR segment. So from the P wave up to the R wave. So that's the PR segment, which is the delay at the AV node. So this is a representation of the conduction pathway. So you have from the SA node, the electric current travels into the AV node and then into the respective bundle of his. So for the QRS complex, that would represent the ventricular depolarization or the actual contraction of the ventricles. And then you have the T wave for the ventricular repolarization. And then you have an isoelectric line wherein there is no electrical activity. So how do you interpret an ECG? So just remember these 4 steps. So first, you have to determine the rate and the rhythm. And then next, you get the frontal QRS axis. So the way we determine the axis in pediatrics is different from the adults. No? So just remember that the ECG in pediatrics is not just it's not the same as the adults. You really have to consider the differences between the two. And then step 3 is for the hypertrophy. You check for presence of chamber enlargement or hypertrophy. And then step 4, you look at the waves and intervals if there are any abnormalities. Okay, so at the end of the lecture, I expect that you can fill up the following to complete your ECG results. So you need to be able to count the atrial and the ventricular rate, the duration of the PR interval, QRS, the QT interval, and determine the axis. So it would be also better if you can interpret the findings that you can see in their ECGs. Okay, so first we determine the rhythm, and then the axis, and then the chamber enlargement, and any abnormalities in the waves and intervals. So first things first, when you're given an ECG, you have to check that the patient, the name of the patient, if it corresponds to your patient, the age of the patient, because the normal values would depend. Again, in pediatrics, everything is age dependent. So it's important that you know the age of the patient for you to know which is normal and abnormal. And then you look at the date and of course the calibration. So how do you know if the ECG is well calibrated? So first, you have to check if that the ECG is at full standard, meaning the for every 10 millimeter, it's equal to 1 millivolts. So for ECGs, there's usually a standardization mark. You can find it in the beginning or at the end of the strip. So it's this rectangular box here, and it should be 2 large boxes or 10 small boxes. So that is the full standard. So what if we say full standard, it means that for every 10 millimeter or for every box, for every big box, for every standardization box, that is equal to 1 millivolt. Diba? 0.1 millivolt in small box. So if you have 10, you have 1 millivolt. So that's the standard. If, for example, you get 5 boxes lang, then whatever value that you get for the mag-compute kayo for the for the Q wave or the PR wave. So whatever value that you get, you have to multiply it by 2 kasi naka-half standard lang. Or if twice, kasi sometimes the waves are very small, so the technicians usually multiply that into 2. So may nakalagay times 2. So sometimes the standardization mark is at 20, so you have to divide it by 2. Okay, for the paper speed, the standard is 25 millimeters per second. So if, for example, especially for young children presenting with tachycardia, the QRS complexes are very much near each other. So if you want to look for the presence of the P wave, sometimes we adjust the paper speed to 50 millimeters per second to make the distances of the RR intervals a little bit more widespread, so you can find the P wave, but you have to divide also the speed by 2 to get the actual value. But the standard should be 25 millimeter per second. Bakit siya important? Kasi if you have an ECG, kunyari binigay sa inyo naka 50 millimeter per second, you might think that the patient has bradycardia when in fact the speed is just not standard. So you have to look at these parameters before you interpret the ECG. Okay, so that's just the start. So let's start interpreting our ECGs. So first step, rate and rhythm. So how do you determine the rate? You get the lead 2 or the lead with the least artifact, and then you measure the number of squares. So this is just an estimate for every 10 large squares. If you have 10 large squares in between your RR interval, RR meaning from the proximal R wave to the distal R wave. So yung interval sa gitna nila, if you have 10 large squares, that's estimated 30 beats per minute. If you have one large square only, that's estimated 300 beats per minute. No? But for more accuracy, we usually do this method, yung small squares. So the Formula 1 use the number of the big squares, but since in pediatrics sometimes the heart rate are very fast, so it would be more accurate if you divide them if you use this formula, the second formula, 1,500 divided by the number of the small squares. So for example, here you have how many small squares? So you have roughly 4 big squares, diba? Or 20 small squares. So 1,500 divided by 20, that would be 75 beats per minute. So that is the heart rate. Okay. So next, once you get the heart rate, you also have to determine the rhythm. So what is a sinus rhythm? You have to check the P wave. So each P wave should be followed by a QRS complex, and there should be a constant PR interval throughout the tracing. So, yan, check for every P, there should be a QRS complex. Tapos hindi siya constant yung distance nila from each other. Okay? And the P wave deflection should be positive in leads 2 and AVF and negative only in AVR. So if you have a negative P wave in other leads except for the AVR, then that is a clue that you might have a different rhythm. That rhythm is not sinus. Okay. So this is just a review of the normal heart rate in children. you have up to 200 in newborns up to 3 months old. For children older than 10 years old, that's approximately the same as the adult values. So it's really important that you know the age of the patient of which ECG are you interpreting. Okay, so again, remember that the lead placement is the basis for a properly preformed ECG. And if there is reversal in the arm leads, it will cause a false P wave abnormality. So remember the placement of the leads. It's important that they are placed where they should be kasi pwede siyang magbigay ng artifacts dun sa mga ECGs natin. Okay, so these are just some of the rhythms that we encounter in pediatrics. So of course, you have the sinus rhythm wherein each QRS complex is preceded by a P wave and the P wave is upright in 1 and AVF. So important yan, memorize nyo yan kasi this is the normal. If it does not fit the normal, then definitely that would be abnormal. Okay, next is ectopic rhythm. So if you have an inverted P wave in 1 and AVL, remember, saan nga ulit inverted dapat yung P wave? In a sinus rhythm, your P wave should only be inverted where? In what lead?
AVR.
Anyone? Okay.
AVR, Doc.
AVR, remember R, reverse, diba? AVR, reverse. So that's the only limb lead that should have a negative P wave. Okay, if you have P wave inverted in leads 1 and AVL, then that would be a left atrial rhythm. While if you find the inverted P wave in leads 2, 3, and AVF, that would be a low right atrial or a coronary sinus rhythm. Okay, so this is an example of different rhythms. Of course, you have the sinus rhythm. We get upright leads, upright P waves in leads 1 and AVF, and there's a QRS for every P wave. And then here, you have an inverted P wave at lead 1. So probably this is a low atrial rhythm, right? How about this one? So most common heart rate variations are not true arrhythmias. So it doesn't mean that this has arrhythmia in its name, arrhythmia na siya. So actually, sinus arrhythmia is just a normal variation. So sometimes child presents with irregular rhythm on auscultation, and when you get the ECG, it's just sinus arrhythmia. So what we do is we just assure the parents that this is a normal variation. Of course, you have to correlate clinically. And this is usually seen in patients, in young children, but less pronounced in infants and adolescents. So sinus arrhythmia, you still have the P wave for every QRS. But the RR interval is not constant. So here you can see that the longest RR interval is roughly 4 boxes or big boxes, while the usual RR interval is 3 big boxes. Okay, so that is sinus arrhythmia. And it is a normal variant. So pag may nakita kayong ganyan, huwag masyadong mag-alala sa rhythm ng patient. But you also, again, you still have to correlate clinically. Okay? Other rhythms include sinus bradycardia or slow sinus rhythm. So you have sinus rhythm, but the heart rate is below what is normal. So that's sinus bradycardia. And if you have a fast sinus rhythm, that's sinus tachycardia. So here are the instances wherein you can see the following rhythm. So sometimes for patients who are aerobically trained individuals, yung mga sporty, yung mga athletes natin, yan, they have sinus bradycardia. Or those with hypothyroidism. Now, we usually see sinus tachycardia, especially in young children. Bakit? Kasi pag dikitan mo sila ng leads, iiyak sila, di ba? So definitely, bibilis na yung heart rate nila. So this is one of the common findings that we see in children, sinus tachycardia. Okay. So what are the other ectopic beats? So we have two. We have premature atrial contractions and premature ventricular contractions. Yung premature atrial contractions or PACs, So they are the abnormal P waves that appear earlier than expected, kaya premature atrial contraction. So they are usually narrow QRS complexes that the narrow QRS complexes to follow the PACs are similar to the normal QRS. But here you can see that there is an abnormal P wave. So you can see the difference from here. So this is sinus rhythm, and then you get PACs. And this is narrow. Remember that PACs are narrow QRS complexes. So if they are isolated, then that's usually benign and it requires no further evaluation. But for frequent PACs, you need to get a 24-hour Holter monitoring or rule out atrial tachycardia. So this is commonly seen in newborn infants. Okay, for premature ventricular contractions, they are wide QRS ectopics naman. So kanina PACs, narrow complex QRS. Ang PVCs naman, they are wide complex QRS and they appear earlier than expected. So the definition is that they are wide, bizarre-looking QRS complexes. Usually different yung axis nila from the QRS in that lead. So here, narito mataas yung R wave. So here, baliktad siya. And if they're normal in 40% of the children, provided that they are isolated or just occasional. If nag-i-increase sila, then that would be a warning sign for us. So it's warranted that we evaluate the child if the PVCs increase in numbers, especially during activity. Okay, kasi remember, if you have at least 3 simultaneous PVCs, then that is already a non-sustained ventricular tachycardia. Okay, so yeah. So look at the intervals of your PVCs. I'm not sure if I have it here, but siguro you've heard of yung mga bigemini, trigemini, quadrigemini, diba? So if you have a single, nawala sa slide ko. If you have a single PVCs, for every QRS, then that would be bigemini. Bigemini kasi alternate sila. And then if for every 3 beats, like this one, 1, 2, 3, if every 3 beats, that would be trigemini. PVCs in trigemini. Kung magkasunod, couplet. Pero pag 3 simultaneous na, 3 na magkakasunod na PVCs, that's already non-sustained VTAC. So you have to monitor your patient for possible development of ventricular tachycardia. Okay, so these are the other normal variations in rhythm. So you have pronounced sinus arrhythmia. For first-degree AV blocks, it may be normal, but it may be also an abnormal finding, especially if it's associated with other symptoms like fever and joint pains, which is seen in patients with rheumatic fever. If you have Mobitz type 1 with second-degree AV block, so these are just the normal variations, but you have to still correlate clinically. Okay. So what are the pathologic tachycardias? So first is supraventricular tachycardia or the narrow QRS tachycardia. Narrow QRS in general, that is 0.09 seconds, but remember, it's age dependent. The normal QRS interval is age dependent, but in general that would be 0.09. So, and the P waves are difficult to see, or it's usually not seen because it's embedded either in the QRS or after the QRS complex. So in pediatrics, if you get a heart rate of more than 220 for infants and 180 for older children, then you have to consider SVT unless proven otherwise. So here you can see what is the heart rate in this ECG. I-estimate lang ilang siya, big box. Hello? Meron pa bang lista? Sige, ilang ano to? This one, ilang ano siya? Ilang big box? Sige, count lang natin, this one,
Dalawa po, Docs.
Dalawa. So, roughly, what is the heart rate? Anong formula natin for heart rate kanina?
1/5 over number of small boxes.
Number of small boxes. So, if you have 2 big boxes, that would be how many small boxes?
10.
10. So, 1,500 divided by 10 would be?
150.
Okay, so it's quite tricky. Hindi natin alam ilang ano to, ilang yung speed, it's not written kasi so we don't know if we have to multiply it or divide it by 2. But if you look closely, you cannot find the P waves clearly here. Diba? But if you look closely, the P waves you can find here after the QRS complex. Here. Okay, so this is an example of SVT. So how would you differentiate sinus tachycardia versus SVT? So again, if in infants, if it's the heart rate is more than 220 and it is fixed, then you have to consider SVT unless proven otherwise. For older children, it's 180 beats per minute. On physical examination, sinus tachycardia depends on its cause, while SVT may show signs of shock, but it's still difficult to differentiate. So you have to correlate with the history of the patient. If there's associated irritability, lethargy, and poor feeding, especially in an infant, then you have to consider SVT. Okay, so what do you have to do? If the child presents with SVT, then you have to do vagal maneuvers. Familiar kayo dun sa vagal maneuvers? What are the different vagal maneuvers that you can do if you see a child presenting with SVT? Yung sa adults, anong ginagawa?
Valsalva.
Valsalva. So, pwede yon if the child is already cooperative and nakakausap na. Okay, so what are the other, what are the other maneuvers that you can do in a child presenting with SVT? Nag-ano na ba kayo, BLS?
Times massage.
Carotid massage. But remember, unilateral lang siya ha. Kasi if bilateral carotid massage, pwede mag-syncope yung patient. So, unilateral lang. Pili lang kayo anong side. Okay? Ano pa? Ano pang ibang vagal maneuvers yung pwede? So, for infants, you can also place ice pack in the face for 10 seconds. So, pwede rin yun. Ano pa ba? For some children, you may ask them to blow in a straw na nasa baso, may water. That would induce Valsalva reflex also. So, yun yung mga vagal maneuvers. But if that doesn't work, you have to prepare your patient for adenosine administration or synchronized cardioversion already. So, this is how you deliver adenosine. You have to get a three-way stopcock, and for example, this is the adenosine. You have to deliver it via rapid IV flush, or rapid IV bolus. So once you flush the adenosine, you have to push the 10 ml of saline rapidly rin. Kasi 'di ba short lang yung half-life ng adenosine. So you have to deliver it fast, kaya tayo magbibigay ng bolus. Okay, so but if you don't have adenosine, you can also do synchronized cardioversion, but make sure that you sedate the patient. Okay, but for intractable SVTs, you have to consider giving amiodarone or medical treatment and ablation therapy if warranted. Okay, so this is the other pathologic tachycardia. So you have ventricular tachycardia, or so yung kanina narrow QRS, this one naman wide QRS. So here in general, that is 0.09 seconds. 0.09 seconds meaning more than 2 small boxes. So if the QRS complex, for example, this one, you already have 3 small boxes. So this is a wide QRS already. And again, you cannot see the P wave. Okay, so this is ventricular tachycardia. Here you have monomorphic ventricular tachycardia. So you can see that the QRS complexes are wide and they are monomorphic. There's just one morphology. Okay. So for patients with ventricular tachycardia, what you can do is do defibrillation or give amiodarone or lidocaine. And of course, you have to determine the cause. If it's reversible, for example, if there's electrolyte imbalance, then we have to correct the electrolytes, do medical management. If the child presents with poor function or channelopathy or cardiomyopathy, then you might consider advise them to have an implantable cardioverter or defibrillator. No? For ventricular tachycardia, if you do see this in a patient with poor pulses or no response, then you also have to do simultaneous CPR. Okay, so that's for the rate and rhythm. Next is for the frontal QRS axis. So in pediatrics, we always give reference to the hexacial reference system. So here, this is the representation of both the bipolar and the augmented unipolar leads. So remember yung kanina, yung mga pwesto nila. So here, you have axis 0 to 180. Yung sa taas is the negative. Yung sa baba is the positive axis. Kasi remember yung conduction ng electricity. If this is the heart, imagine that this is the heart. The flow is from the SA node to the AV node to the respective bundle of fluids. Okay? So, next you get the deflection. So, if the R wave is higher than the S wave, then that is a positive deflection here. If the S wave is deeper than the R wave, then that is a negative deflection. While if you have equal R wave and S wave, then we call that equiphasic QRS complex. So how do you get the QRS? So we plot. So we always have this picture with us whenever we read our ECGs. And then you plot per lead. Okay, so for example, here you have leads 1, 2, 3, AVR, AVL, and AVF. So, sige, i-plot natin siya. For the lead 1, here, yung horizontal, is it positive or negative? This one, positive or negative deflection?
Positive.
Okay, positive. Guys, mas masaya kung interactive tayo, no? So, I would really appreciate if, kasi if you join dun sa on how we perform yung activities natin, then mas matatandaan nyo siya rather than just letting my words roam into your ears. So, yun. Mas maganda if you answer para ma-practice din kayo. Okay? So, for lead 1, positive tayo. Okay, so, dito siya sa positive. For example, this is the ito yung representation ng lead 1, so 180 to 0. So you have a positive wave, kaya dito siya. Dito na siya ipa-plot. How about for lead 2?
Positive also.
Okay. So positive din siya. So this is lead 2 from 60 degrees or negative 120 to positive 60. So here, dito yung lead 2. Okay? Lead 3, positive or negative?
Positive also.
Thank you, Dr. Makamay, for joining me here. Okay, so positive ang lead 3. So you plot it here. Ito yung lead 3, sa positive 120. So dito siya. Okay. Lead AVR, positive or negative?
Negative po.
Okay, so negative. Negative. So kung AVR, dito tayo kung dito siya, di ba, ito yung positive niya. So sa kabilang side. So dun yung negative niya. AVL, positive or negative?
Negative.
Positive.
Sige, look closely. So yung R wave,
euphasic po, Doc.
sorry, ano?
Euphasic? Siya na ba ito?
Sige, tingnan natin. So here, yung R wave, ilang box? Ilang small box yung R wave? 1 box lang siya, no? How about the R wave? It's 2 boxes. So therefore, it is mas malalim yung S.
Negative.
So malalim yung S compared sa R wave. So this is negative. So dito siya. If this is your AVL, then you plot it in the negative side. Okay? So when we draw the hexagonal reference system, yung tuloy-tuloy na lines, that is the positive part, and then yung broken lines, that is the negative. Okay, so last one, AVF, positive or negative?
Positive.
Okay, so positive ang AVF. So you plot it here on the positive side. Okay, so once you've plotted all the all the 6 leads, you get the middle. So the middle would be in between 60 to 90 degrees. So that would be 75. Okay, so bakit ganun? Kasi, di ba yan, 90 degrees yan. So 3 sila na nandyan. So 30, 60, 90. And yung gitna, nung plot natin is at the 75th degrees. So that's 75 degrees. So that is the axis of your patient. Okay. Now, what would you do if there is an equiphasic? So for example, this is an example of an equiphasic QRS. Here you have lead 3, which is equiphasic. So once you get an equiphasic QRS, you look for the perpendicular lead. So for lead 1, yung perpendicular sa kanya is the AVF. For lead 2, AVL, yung perpendicular. And for lead 3, AVR. So for example, lead 3, ang perpendicular sa kanya is AVR. So you look at that, you look for the direction ng QRS ng AVR. Sorry, this is the AVR. So here, you can see that the AVR is negative. Sorry, ayan. So here you can see that it is negative. So for example, if this is lead 3, you get the negative side of AVR, then that would be your axis. So here, the axis is plus 30. Okay, kuha niyo yun? Hello?
Opo, Doc.
So yan, yung pag-equiphasic, yun yung pwede nung gawin. But for the others, you can plot. You have to plot. We don't use the formula. Okay? So this is just an example of normal QRS axis. For children, for infants, we can have up to positive 180. So that would still be normal for them. But for children more than 3 years old, we get only up to 120. If you have a 180, that's already right axis deviation. Okay, so ito yung shortcut dun sa na ginagamit, but we don't usually practice this for children. Ito, eyeballing lang siya. So, kunyari, you just look at lead 1 and AVF. So, kung positive parehas yung lead 1 and AVF, that's in the normal axis. For, if negative si AVF, then that's left axis. If negative yung lead 1, that is right axis, and if both negative, extreme right axis deviation. But this is only applicable for older children. For remember, iba-iba kasi yung normal values ng axis for them. So, dito, pwede nyo lang sila i-apply if adolescents na or older na yung child na ECG na binabasa. Okay? Now, if you have, the QRS is normally positive in AVF. If you get a negative QRS in AVF, that would be what we call the superior axis. So if you get a superior axis, it is pathognomonic of atrioventricular septal defects or univentricular heart. So for example, if you have a patient with Down syndrome, diba, if you remember my last lecture, diba, if Down syndrome, 50% of them will have congenital heart disease and 50% will have AVSD. So if you don't have someone to do the echo, you can do an ECG. If you see a superior axis, then most likely your patient has AVSD. Ayan, so negative sila, parehas. Okay, sige, sandali na lang. At this point, may questions ba kayo dun sa rate, rhythm, and axis? I hope the silence means we understood everything. Okay? Sige. Next is evaluate for chamber enlargement and hypertrophy. Ito, kahit na cardiologist ka na, minsan nagtitingin pa rin kami sa kodigo namin kasi mahirap siya. You have to memorize. No? But here are the yung mga clues paano mo masasabi if there's chamber enlargement or hypertrophy. So for right atrial enlargement, it is characterized by peak P wave. So you look at bleeds 2 and V1. If the height of the P wave is more than 3 millimeters, that's already peak P wave. So for children younger than 6 months, mas mataas yung cutoff, 3 millimeters. But for older children, more than 6 months, more than 2.5 is already a peak P wave. So if you see peak P wave, that is RAE. For LAE, that is notched, widened, and biphasic P wave. So for lead 2, the usual P wave duration should not be more than 3 squares, 3 small squares, so, or 0.09. Pag mahaba na, pag malaki na yung wide na yung P wave mo, then that would be possible left atrial enlargement. O yung iba, nakikita na talaga notched siya, parang may indent yung P wave mo. Okay? For RVH, you really have to memorize this one. So we check that per leads. Kung yung RV1 ba na, more than 20, as in V6, more than 7, ayan, nagbibilang talaga tayo. Kaya important yung calibration kasi para accurate yung measurement mo. One thing that you have to remember is yung upright T. So if you do see an upright T in V1 after, iba-iba, depende sa literature. So here 3 days, but for some, 7 days to 7 years. So in children kasi, ang character ng T wave mo, at birth, upright siya. And then mag-i-invert siya after 7 days. And then babalik siya to upright after 7 years or in adolescence. So if you see an upright T wave from 7 days old to 7 years or less than adolescent, then you might consider presence of RVH, right ventricular hypertrophy. No? But if you see an upright T wave in a newborn child, kunwari kakapanganak pa lang nag-ECG ka, or in adolescents, upright T wave, then that is already a normal finding. Okay? Also, if you see an RSR pattern, meaning R, then you have S, it will dip into the S wave, and then you get another R prime pattern. So, wherein the R prime is taller than the R, then that is a possible clue that your patient has RVH. And then another thing is that if you look at the V1, if you have a pure R wave, meaning wala kang S wave or Q wave here, if there's pure R wave after the age of 6 months, then that is an indication that the patient has RVH. Okay, so LVH, ito naman. So you can take a screenshot of this slide. I can also give you my slides. Sana maintindihan nyo. Yun. Mahirap siya. Mahirap talaga at this point. Kahit na intern or resident, mahirap ang ECG. But ang important lang kasi dito is that you know what is normal and abnormal for pediatric ECG. Para kahit hindi kayo mag-pedya, hindi kayo mag-cardio, alam nyo na may something. You will know when to refer. Okay, so these are the values that you have to look at the ECG to say that there is LVH. So, yung isang clue dyan, di ba, you look at the chest list, di ba, V1, V2, V3, V4, V5, V6. So, for RVH, di ba, remember, sabi ko, yung V1, matangkad yung R wave sa V1. So, that is RVH. Ang LVH, baliktad. Yung R wave ay matangkad sa V6. Kasi if you remember the placement nung chest leads, di ba pababa sila? Yung kanina yung drawing natin, yung placement ng V1 to V6. Yung V6 nyo nasa, sa mid-axillary line na, di ba? So, mas nagiging positive deflection siya kasi nandoon na yung location ng current, di ba? Pababa yung current ng conduction. So, pag LVH, mas tumatangkad yung R wave niya. So, yun. Kapag RVH, mas matataas yung R wave sa V1 nyo. Pag LVH, mas mataas yung R wave sa V6. So, true enough here, yung RV6 mo, more than 25 millimeters. Yung S in V1 naman, yung mataas din. So, RVH baliktad. R in V1 yung matangkad, S in V6 yung madami. Okay? So, shortcut, LVH, one rule. You just look at V6 here. If the R wave in V6 intersects the baseline of the lead V5 in a standard ECG, then that would be LVH. Okay? So, but sometimes this is unreliable, especially for children with very thin chest walls. Tsaka minsan kasi kinakat nila yung calibration, so hindi na umaabot sa V5. So you really have to count and look for the different waves. So this is an example of LVH. Here you can see that there's a tall R wave in V6 and that there's a deep S in V1. Also, you can appreciate ST segment depression in V5 and V6, which is what we call the strain pattern. So in this case, probably your patient has a severe LVH already. Okay, so next is combined ventricular hypertrophy. So if you see both signs of both LVH and RVH, then syempre combined kasi parehas left and right ventricular hypertrophy sila. Also, if you look at leads V2 to V4, here ayan, V2, V4, you can see that there's very tall R and deep S. So if yung R plus S mo is more than or equal to 60 millimeters, that is what we call the Katzwachtel phenomenon. If you see that, yung Katzwachtel phenomenon, that is a combined ventricular hypertrophy. Wait lang. Okay. Okay, so last step, yung PR, QRS, QT. So we will discuss each wave and interval. Yun na lang yung last part natin. Okay, so P wave, again, the direction should be positive and upright in all leads except ABR. So ito siya, ito yung P wave. Yung duration should be 0.10 seconds or less. Amplitude should be 0.25 or less than 0.3 millimeters. Kasi remember, if more than 0.3 or if more than 0.3 millimeters na siya, then that's already peak P wave or right atrial enlargement. It should be smooth and rounded, and it should be followed by a QRS complex. PR interval from the beginning of the P wave up to the beginning of the R wave. Okay? Yun yung interval. Different siya sa PR segment. PR segment is after the P wave, before the QRS. Okay? The normal values should be 0.2 seconds, 0.12 to 0.2. If more than 0.2 seconds or ilang ano yon, ilang small box ang 0.2 seconds. Sige, di ba per small box 0.04? So ilang box yun, yung 0.2?
5.
5, oo. So pag makakita kayo ng more than 5 small boxes na PR interval, there's already an abnormal that's already an abnormal finding. It could be the first degree AV block already. Okay? So this is the PR interval according to age. So if you can see here, yung 1-month-old hanggang 0.09 or 0.10. So meaning 3 small boxes lang sila. But as the child grows older, nagiging 0.15. So adults 0.2, di ba? Yung maximum. So kunwari nag 6 small box na 7, that's already first degree AV block. Okay, so for the simplified method, it's more important to recognize the presence of an AV block than to specify the degree of AV block. So for your level, important na yung masabi mo na may AV block, na hindi siya normal. Better na yun na identify mo siya. Okay, so what are the different AV blocks? First is yung first degree AV block. You have P waves, and a QRS complex follows every P wave. The P wave morphology is normal, and the PR interval is constant, but it is prolonged. It's more than 0.2 seconds or more than 5 small boxes. So here is an example of a first degree AV block. As you can see, the PR interval is already roughly 8 small boxes na siya. 8 to 10 na siya, di ba? Dito. So this is already first degree AV block. Okay? And then you have second degree AV block. You have two. You have the Movitz type 1 or the Wenckebach phenomenon and the Movitz type 2. 1 for Wenckebach. So for second degree AV block, meron kang skip beats or drop beats. Again, there are P waves. You have QRS complexes following the P waves, but there is progressive prolongation of the PR interval until there is a drop beat. So pahaba ng pahaba yung PR interval mo. For example, here, you can see that the PR interval prolongs. Yan, dito 6 pa lang, then dito naging 10 na. And then there's a skip beat. Skip beat meaning wala siyang QRS complex. You have your P wave here and another P wave here. So walang QRS. So that is type 1 of second degree AV block. Okay, so for Movitz type 2, ganun din, there is a skip beat. but the PR interval may be normal or long but fixed. So, persistently long na yung PR interval, baka dito, baka ma-miss nyo siya, naisip nyo, first degree AV block lang siya kasi prolonged yung PR interval. But look here, in between P waves 3 and 4, wala kang QRS. So, that is your skip beat. Okay? For third degree AV block, walang pakialamanan yung P-wave and the QRS complex. So, the QRS are normal in shape, duration, and axis, but are often abnormal and of constant morphology. No consistent or meaningful relationship between the atrial and ventricular activity. And the rate, QRS rate is within the range of 15 to 70 beats per minute. So, for example, here, you have to identify which is the P wave. So, ito siya, yung triangular na wave. So, here, you have P waves here, here, here. Yung red arrows, that corresponds to your P waves, and then yung blue arrow corresponds to your R wave. So, remember yung ECG result natin, di ba, you have to compute for your atrial rate and ventricular rate. So, dito na siya kukunin. Yung ventricular rate, you just have to count for the number of small boxes divide 1,500 by the number of small boxes. For the P wave, yung PP interval naman. So, for example, here, yung R wave mo, it's roughly 7 big squares. So, 1,500 divided by 35. Ilan yun? 300, 150, 100, 70. Roughly nasa 50?
43.
42.
42.86.
So 42. So yun yung ventricular rate. How about your atrial rate? So ito, ilang box sila? Roughly mga 17 or 18 small boxes. So ilan yun?
Around 83, Doc.
Nasa 80s, no? So, ayan. So, sa ECG result nyo, yan, magkaiba yung ventricular rate and atrial rate. Yung magmamanifest sa patient nyo is yung ventricular rate. So, pag i-auscultate mo siya, bradycardic siya. Nasa 40s lang yung heart rate. No? But the ECG result would be like this. Okay? So, that is considered a third degree AV block, or that is already a complete AV block. And these are the following conditions that may manifest with AV block, a complete AV block. So you have myocarditis, you have congenital heart block, especially with children born to SLE mothers, for patients who underwent cardiovascular surgeries, and the treatment could be either temporary pacemaker implantation, or if it's persistent, then that would warrant a permanent pacemaker implantation already. Okay, so again, this is an example of a third degree AV block. So, tingnan niyo yung heart rate dito, mas matagal yung RR, mas mahaba yung RR interval compared sa PP interval. Okay? So, ito, yung mga mahilig humugot dyan, para maalala niyo yung mga AV block. So, ano ba? Ayan, normal sinus rhythm. Hindi sa akin galing to, nakuha ko lang somewhere. So, normal sinus rhythm, parang sa relationship, normal lahat. So, nasaan si P, si QRS. Walang delay, constant yung intervals nila. 0.12 to 0.2. First degree AV block, medyo meron ng delay. Nag-more than 0.2 seconds na. So, that's first degree AV block. Second degree AV block, pag Mobitz type 1, pahaba yung time paghihintay ni QRS hanggat sa hindi na darating si QRS at all. May skip beats na. Kung type 2, palagi ng late, tas biglang hindi na lang magpapakita. So yun yung type 2. Type 3, wala na silang pakialam sa isa't isa. So kanya-kanya na sila. Si P-wave, may kanya-kanya ng rhythm. Wala na siyang kay QRS. Okay? So, yan. Para lang maalala nyo kasi para pag kunwari mag-moonlight kayo, makakita kayo ng mga waves, ay mga ECGs, alam nyo na may something. Yun lang yung important sa ngayon. Alam nyo abnormal yung ECG. Okay, so yan. QRS, from the beginning, yung Q wave up to the end of the S wave. So, kaya siya complex. Okay, and it corresponds to the ventricular contraction. The duration is 0.10 seconds or less. Remember, if more than 3 small squares or 0.12, that's already wide QRS. So again, wide QRS, if more than 2 small boxes, if you have a wide QRS, then you consider presence of bundle branch blocks, premature ventricular contractions or PVCs, Wolff-Parkinson-White or ventricular rhythm. So ano si Wolff-Parkinson-White? So if you do see a patient with SVT, and then na-convert nyo na sila, i-check nyo ulit yung ECG kasi baka meron silang Wolff-Parkinson-White syndrome, meaning ano sila, predisposed sila into having supraventricular tachycardia. So, WPW, you have a wide QRS complex, and then you have a short PR interval, and then you have the delta wave. Yung slurring of the QRS complex, that is the delta wave. Okay, so for example here, short PR interval and then slurred siya, unlike your usual QRS complex. So this patient has WPW. For right bundle branch block, you have the RSR prime pattern in V1, and you have wide QRS. Compared dun sa kanina, di ba nabanggit ko, pwede siyang RVH, but the QRS complex is narrow. If your QRS complex is wide with the RSR pattern, then that is right bundle branch block, RBBB. Ang ano ko dyan, rabbit bunny ears, yung tawag dyan. So rabbit bunny, ano ba? Basta rabbit bunny ears, parang, ewan ko, since med school, yun na yung naalala ko kasi RB, diba? Right bundle. Yan. It may be a normal finding. It may also be seen in the following conditions. So, yung myocarditis, ASD, the patients with Ebstein's anomaly, and following cardiac surgery. Left bundle branch block, it's rare in the pediatric population. Here you can see that the RSR pattern is in V6, and there's slurring of the S wave in V1. Okay, so this is rare in children, but if you do see this, it's definitely pathologic. Okay, sometimes you can see incomplete right bundle branch block. So these are RSR pattern in V1, but with normal QRS duration. So yan yung mga, minsan makita nyo incomplete right bundle branch block. Those are just findings. It doesn't mean that there's a specific disease associated with it. You still have to correlate clinically. Okay, so if you do see incomplete RBBB, then it may be normal, but you have to rule out presence of cardiac anomalies. Okay. Other findings include low QRS voltage. So, how low is low? So, pag ganyan, again, check your calibration. Baka kasi masyadong maliit. Pag normal naman calibration, if less than 5 millimeters in beam leads and less than 10 in precordial leads, then that's already low QRS voltage. And you can see that in patients with myocarditis, pericardial effusion, or in patients with generalized edema. Or yung mga medyo chubby na patients, ayan, sometimes low QRS voltage sila kasi thick yung chest wall. Okay? Q wave naman, it is the septal depolarization. So sometimes you see non-pathologic Q waves that are less than 2 small squares deep and less than 1 small square wide. Hindi natin siya masyadong kasi sa adult yung mas particular sila sa mga Q waves kasi it may be an indication of ischemia. For T-wave, again, di ba, normally upright until 7 days of age, and then it becomes negative between the 7 days and adolescence, and then it reverts back to upright again in adolescence and adulthood. So if abnormal siya, if upright siya in between 7 days to adolescence, then that would be RVH. Okay? Sometimes the T-wave also gives a clue on the electrolyte status of your patient. So you have abnormal T-waves. If you have, so ano siya, reflective of the potassium status. If there is hyperkalemia, you can see tall and peak T-waves. So for example, meron kayong patient na kinuha ng electrolytes. Tapos lumabas 7, potassium 7. Siyempre, alam niyo ba yung implication ng mataas ng potassium? Kasi it's actually, di ba yung mga lethal injection, yung isa sa mga ini-inject, isa sa mga drugs na ini-inject is potassium. So, very high levels of potassium is lethal. So, if you do see a 7 na potassium, sobrang taas na nun. So, how would you react? So, paano malalaman kung magpapanik ka na ba or baka kasi minsan, lalo na pag yung maliliit na bata, tas yung pag-extract mo ng blood through yung syringe, pwede kasing na-hemolyze, di ba? Ang potassium intracellular component siya. So, pag nag-hemolyze yung blood, it may give you false elevated potassium levels. So, how would you know if nag-hemolyze lang yung sample mo or significant yung potassium levels niya. So one thing that you can do is to get an ECG strip. So if may changes ka na sa ECG mo, makita mo, kasi mas mabilis yun, di ba? For some laboratories, ilang hours before natin nakukuha yung results. So mas mabilis ka makakuha ng ECG compared sa mag-re-extract ka ulit. Kasi una, mahirap pang mag-extract, lalo na yung maliliit. So, para malaman mo if significant or not, you hook your patient to the cardiac monitor or you get an ECG strip. Then you look for the T-wave. If there is hyperkalemia, there's already peak T-waves. Okay, same goes for hypokalemia. Pag hypokalemic naman, you will see flattened or inverted T-waves. Alas di mo na siya makita or inverted na siya. Okay. So in QT interval, from the beginning of the QRS complex up to the end of the T-wave. And 0.44 is abnormal. Yung QT interval, we have to correct it for the heart rate. Yun yung QTC or yung corrected. So, yun yung mas important kaysa dun sa actual. Prolonged QT interval may be an indication of a congenital problem, o yung mga prolonged QT syndrome, or maybe secondary to antiarrhythmic drugs like your digoxin toxicity, or if there's electrolyte imbalance like hypocalcemia. So how do you compute for that? This is the formula, yung Bazet formula. So sa lahat ng intervals, ito lang yung may formula na kailangan ng tandaan, yung Bazet formula. So you get the QT duration. So here, QT. So yung actual QT is from the beginning of the QRS to the end of the T-wave. So that's roughly 10 small boxes, diba? So 10 small boxes times 0.04 is 0.4 seconds. Okay, and then you get the square root of the RR interval. Here, the RR interval is 20 small squares. So 0.04 times 20 is 0.8. Then you get the square root of that would be 0.89. So 0.4 divided by 0.89 is 0.44. So sakto lang siya. But it also depends on the age of the patient. Siyempre, pag younger patient, mas shorter yung normal QTC nila. 0.44, it's just generic. If you see a patient with prolonged QTC, more than 0.44, then that's definitely, you have to evaluate for the cause of the prolonged QT interval. Okay? So ito yung mga long, kasi we have what we call the long QT syndrome. So these are congenital arrhythmias. These patients are prone to torsadepon. So sila yung mga, pag may mga long QT syndrome, ito yung mga history niyan, merong mga patient kami nun, sumakay lang siya ng Ferris wheel. Ferris wheel ba yung, ano ba yung ganon, yung mataas? Ferris wheel ba yun? Ferris wheel yan, di ba? Yung mataas. Yung sa mga rides, ayun. So, wala siyang Ferris wheel or roller coaster yata yun. Basta yung mas nakakatakot. Yung roller coaster. Sumakay siya ng roller coaster, hindi natakot siya. Tapos sa pagbaba niya, syncope na siya. Tapos yung pala, nagtatachyarrhythmia na siya. Kasi apparently, that patient has long QT syndrome. So, yun. Kaya, you have to compute for the QT interval. Okay, so, U wave, we don't usually see the U wave, but if you do, it's reflective of the final stage of repolarization, and it's always smaller than the T wave. Okay, if it's taller than 2 millimeters, then it may suggest hypokalemia, or it may be secondary to digoxin toxicity. Okay, ST segments, we don't usually see this in children, but if you do see ST segment changes, if it's more than 1 millimeter, then that is already elevation. And if it's below 0.5 millimeters or half a box, that's depressed ST segment or ST segment depression already. Okay, for calcium levels, hypercalcemia, you have short QT intervals, normal, hypocalcemia, there's prolonged QT interval. Okay, so I will not be dwelling on the other findings anymore. I think for you, masyado nang overload yung whatever I've discussed today. So I hope that when you go into the clinics, you try reading the ECG tracings yourself first. Ay, sorry, hindi ko nababasa ang mga hindi ko nababasa mga chats. I'm so sorry. Pero yun, I hope when you see me in the clinics, marunong na kayo magbasa. Kahit yung lang, hanggang heart rate, tsaka axis. Happy na ako doon. Or sabihin nyo, Doc, parang abnormal yung ECG. Yan. Okay na ako doon. Ma-detect nyo lang na abnormal siya. So, when I see you, I'll be coming back next year. Ano na ba kayo nun? Clerk na kayo nun? Next year? Clerk, ano na ba kayo ngayon? Sorry, I'm very confused.
Third year po.
Third year. So next year, tama, clerk na kayo next year, diba? Magra-rotate na kayo sa pedya?
Oo, ando.
Sige, pag may ECG yung patients, papabasahin ko kayo. Kasi tatandaan ko na, tinuruan ko kayo ng ECG, so dapat marunong kayo ng slide. Kahit yung heart rate lang or axis, pwede na ako doon. So yun, and then you try, lang siya, practice talaga siya. You just practice, and then you have someone check para when you read ECGs on your own, you will know kung tama ba yung basa ninyo. Okay, so I'm open to referrals. So if you have ECGs you want to have me check your ECG readings, okay lang yun. Just send me a message. Okay? Teka, yung game natin hindi pa tapos. Wait lang, check ulit. Just give me 5 minutes. I'll check yung Sayang kasi yung pa-Gcash ko, pinaghandaan ko yung, pinagpaguran ko yung 200 pesos. Wait lang, I'll check yung Okay, sige. Ganito. Ulitan na lang. Sorry na. Ulitan na lang. Para equal billing kayo. So, bonus na lang. Bonus kay Papagad na maaga kayong pumasok. Yung mga nauna kanina. Tapos ngayon, para lahat kayo makasali. Sige. Equal billing na to kasi nasabi ko na yung mga sagot sa lecture ko. Okay. Sige. Ayan. Kita nyo ba? Sige, join na kayo ulit. Na-reset ko yung scores. So yung mga na late na magpindot kanina, may chance kayong humabol. Okay. Ay, doon sa mga na-late, ang GCash price natin ay 200 pesos. Mataas na yun Parang ano na yun, pang raffle. Sige. So, you can scan the QR code or just go to www.menti.com and enter the code. Sige na. Last na lang to, promise. 1/3 pa lang. 1/3 na lang yung nakaabot ng attention span dito. Okay. Sige. Wala na bang sasali? You only have 26 out of 73. Pinaghirapan ko to, mga 5 minutes before the lecture. Sige. Ulitan ha. Sige. Let's go to the first question. Okay? 7-year-old boy with irregular heartbeat. The fastest answer gets more points. Dapat pala idiklian ko, no, yung 30 seconds. Pero sige. Okay. Naku. Meron pa rin hindi nakakuha. Pero sige. It's okay. Baka na mali lang pindot. So, that's sinus arrhythmia. Okay. Ayan. At least yung mga sumali kanina, sumali sila ulit. Very good. Okay. Next. Two-day-old presenting with irritability and poor perfusion. Okay? So again, SVT yun kasi narrow QRS complexes. Less than 2 small squares siya. So SVT. Okay? So, ang nangunguna ay si Gigi. Sino ba si Gigi? Okay, next question. Okay? So, yun, wide QRS complexes naman. Kaya siya ventricular tachycardia. Okay? So, top scorer is Branda Broken. Okay. Sige. Doon sa question number 4, sige, ganito. Pag yung number 5 hindi gumana, hanggang question number 4 na lang tayo kung sino yung mananalo doon. Pero pag gumana yung 5, di sige, sali natin number 5. Okay, question number 4. Yan, newborn patient with mother, born to a mother with lupus. Okay? So, complete heart block na yun kasi wala nang relationship. Remember, yung mga P-waves, no, wala na siyang QRS pagkatapos niya. So, that's already complete heart block. Okay? At ang nanguna ay si marami tayong fastest, no? Pero ang nangunguna pa rin ay si Branda Broken. O sige, ganito. Pag gumana yung question number 5, o di kung sino manalo doon. Pero kung hindi siya gagana, ang panalo ay si Branda Broken. Okay? Sige. Mag-unmute naman kayo para ma-feel kayo. Natutuwa kay Dr. Margallo, medyo animated siya masyado. No? Pero at least nakikita ko na may nag-enjoy sa pag-games ko. So sige, mag-unmute kayo para ma-feel ko naman yung party ambience. Sige. O, last question. Alam mo, ayaw talaga niya. So therefore, ang nanalo ay si Brand the Broken. Kanina nag-work na siya eh. Anyway. So ang ating winner ay si hala, sino siya? Unfair. Sorry, number 88. Pumindot ka. Pero ang, sige, tingnan natin yung pinakamarami. Ang highest points ay si, kasi hindi kasali yung question number 5. So, ang winner pa rin ay si Brand the Broken. Okay. Oh, last na lang. What is your favorite rhythm? You just type. Paanong feel mong rhythm mo? Actually, hindi ko alam how this slide works, pero sige, type lang kayo. What is your favorite rhythm? Rhythm of whatever. Sige, napatulan na naman to. Pinaghirapan ko yan. Rhythm, gusto ko yan. So, rhythm of the night. Uy, merong si Rhythm ng jowa niya. Assist ulit. Sige. Last 5 seconds. Sa mga papatol sa aking pa-rhythm. Sige, para may word cloud tayo for the day. Tapos i-screenshot na yan. Tapos wala lang. At least meron kayong screenshot ng word cloud ng ECG lecture natin. Kasi na si Nisa. O tandaan niyo yung spelling ng rhythm, ha? Ganyan. Alam mo, forever rin akong litong-lito sa spelling ng rhythm. Okay? O yan, sige, you can take a screenshot of this word cloud. At ang ating rhythm ay normal rhythm. Okay? Sige. So, sinong nanalo? Okay. So, ang nanalo ay si Branda Broken. Do you want to reveal yourself?
Reveal.
Sino si Branda Broken? Wala, sayang yung pa-Gcash. Totoo yan. Sino ba yung binigyan ka ng Gcash last time? Meron talaga akong binigyan. Sige, sino si Bran? Kung nahihiya siya, May, ikaw na lang maghanap sa kanya. Or you can send me a message sa Kasi pag, di ba, pag kunyari hindi tayo friends, nandun sa request, hindi ko nababasa. Pero just try. Basta, kung sino man si Branda Broken, I'll give you a Gcash. Just send me a message, okay? So, do you have questions sa lecture natin? Wala. May natutunan naman kayo. Mahirap siya talaga, pero it's okay. You need to get, siguro in your lifetime, lalo na kung magpe-pediatrics, yung marami kang lecture ng ECG, eventually makuha nyo rin siya. Okay, so huwag kayo masyadong masad kung hindi nyo siya na-gets ngayon. Okay, so again, thank you everyone for attending our lecture kahit late na. Sige.
Thank you, Doc. Merry Christmas.
Merry Christmas. Ay, magpipicture ba tayo?
Done na po, Doc.
Meron na. Naku, baka nakapikit na naman ako.
Sige po, Doc.
Hindi, okay lang. Joke lang. Kasi yung mga picture palagi, either hindi ako nakatingin kung saan na waki yung mukha ko. Anyway, sige, thank you everyone. Good night.
Thank you, Doc.
Bye.
Bye.
Thank you, Doc.